Good morning, everyone. Thank you, Dr. Vijay, for this wonderful opportunity and this lovely conference. My job is to talk about the role of Transhiatal Esophagectomy in managing carcinoma of G junction. I just want a show of hands from the audience. How many of you feel that trans-thoracic esophagectomy is the ideal technique for managing a carcinoma esophagus? Can we have a show? How many of you feel that trans-thoracic esophagectomy has better survival than transhiatal? Very few. And how many of you, does anybody feel THE should not be done for CA-G junction anymore? Any show of hands? There are a few. How many of you do THE for managing CA esophagus in the audience? We have very high volume surgeons here. How many of you do? Anybody? Rajesh sir, 1, 2. Okay. So as you can see, THE is not the most favored operation. There is only one or two hands I saw going up where we do it as a treatment for CA-G junction. And this slide also reflects the same feeling across the world. This is the data from the UK experience where only 4% of carcinoma esophagus, including all levels of esophageal cancers from thoracic to G junction, only 4% was being managed with THE. So why did THE go out of favor from the practice? I am sure that many of us, the senior surgeons here must have seen and even done a lot of THE during their initial surgical training. And the present day trainees, I don't think they get to see even one THE in their entire 3-year training period in many centers. So the main criticism of THE was it's a blind procedure. It does not give you a good lymph node yield. It cannot identify the lymph node stations, and there are a lot of complications because it's a blind procedure that like bleed, tracheobronchial injury, etc. But let's see what the evidence says about this. Is it actually true? So aim of surgery in carcinoma esophagus is to improve the quality of life. Whatever surgery you do, finally the patient will end up with a better quality. Try and prevent recurrence and then improve the survival. And types of lymphadenectomy, this is just one slide. There are 3 major types. One is standard, second is extended, third is 3-field. Standard is only the abdomen and up to infracarinal. Extended, you go on to there are 2 types. You go from the infracarinal onto the right side, and total mediastinal is the other subtype of extended. 3-field is where you also do a cervical component of it. So to evaluate the value of THE in managing G junction cancers, does it have an advantage? There is sufficient evidence to support this. This is a large meta-analysis which studied 2,000 odd patients from 18 studies. It compared trans-thoracic versus THE. But the problem was most of this was from the pre-neoadjuvant era, and the surgery which was done was Ivor Lewis mostly. So in this slide, just focus on this point. This slide actually showed some advantages of TTE over THE in terms of lymph node harvest, where TTE was better. THE showed better operative times and lesser blood loss. But when they matched these studies for heterogeneity, all these differences disappeared, and it was found that there was no difference between trans-thoracic and transhiatal esophagectomy in terms of any of the advantages. Then there was a meta-analysis done specifically focusing on the difference between these 2 procedures in Siewert type 2, which is the most controversial area. There again they found there was no difference in complications, no difference in the R0 resection rate or perioperative mortality. In fact, THE was found to have a better 3 and 5-year survival rate. The reason for this is not known. It also had lesser pulmonary complications, like we all know, and the operative blood loss also was less. There was actually an RCT conducted to study if THE and TT, which one is better. This included 220 patients, and it included all the patients with mid and lower esophageal adenocarcinomas. Again, this was not a recent one, it's in the pre-neoadjuvant era. And here they found that THE had better morbidity, lesser blood loss, and lesser hospital stay, like expected. And the 2 main criticisms of THE on lymph node yield and artery resection were put to rest. There was no difference between these two procedures in terms of lymph node yield or artery resection rate. When they saw the survival, you can see that up to 3 years there was no difference in survival between TT and THE, and there was an advantage for trans-thoracic esophagectomy at 5 years.